Chapter 44, Acute Disorders of Brain Function. In this chapter, we'll discuss brain injury. We'll look at the impact of hypoxia and ischemia on the brain, and then we'll discuss normal blood flow to the brain, so cerebral blood flow, and then we'll end with strokes and seizures. So let's start off by talking about conditions that can cause injury to the brain, and then look at some common pathways through which brain damage actually occurs. So some common conditions include a traumatic brain injury. So if you're in an accident, that would be considered a traumatic brain injury. We also have tumors. So if you have a mass, a growth in your brain, that is a condition, as well as a stroke, metabolic derangements, and then different degenerative disorders. Now, whatever your condition is, the common pathway through which brain damage occurs includes the effect of ischemia. So that interruption in blood flow causing the injury. So for example, you have, let's say, a tumor that is compressing a blood vessel, and that's causing decreased blood flow to the brain. Excitatory amino acid injury like glutamate, cerebral edema, as well as increased intracranial pressure. These are all common pathways of brain damage. So quick question, which of the following is not a common cause of neural injury? So if you take a look, we just discussed ischemia, excitatory amino acid, cerebral edema, and then increased intracranial pressure. Now, recreational drug use, of course, can cause brain injury, but it's just not a common cause. So let's discuss the difference between hypoxia and ischemia and its impact on the brain. So hypoxia is basically low oxygen. So what's important here, though, is that blood flow is still maintained. It's just that the blood does not contain a lot of oxygen. As a result, it causes an ATP depletion. So remember, we use oxygen to make ATP. We do aerobic metabolism. Without enough oxygen, we won't be able to do aerobic metabolism, and as a result, we're going to make less ATP. So that's where the power failure comes in. And if you recall, we talked about different ways you can get cell damage. And one is if you don't have enough ATP, then your sodium-potassium pump may not be running like it should. And so it causes your cells to swell up with water. So if you recall, the sodium-potassium pump pumps sodium out of a cell. If it can't pump because you don't have ATP, that sodium stays inside your cell. And we know that water follows sodium, so then water will enter into our cell, causing our cells to swell. And if you recall, we talked about different ways your cells can get injured, and hydropic swelling was one of the reversible types of cell injury that we discussed in the beginning of the term. Without enough oxygen, we will go to doing anaerobic metabolism to make energy, and first of all, that creates less ATP. So with aerobic, we can make up to 32 ATP per glucose. With anaerobic, we're only going to make 2. And in addition, with anaerobic, we make lactic acid as a byproduct. So we have to think about metabolic acidosis and then the negative impact lactic acid buildup can have in our cells, like damaging our cell membranes or our intracellular structures or our DNA. Now, what about ischemia then? So ischemia is an actual interruption in blood flow or a decrease in blood flow. So your tissue that is after that interrupted area will get less oxygen, of course, but here you're also getting less blood. Okay, so in hypoxia, blood is still flowing, there's just less oxygen in it. In ischemia, you're going to get less oxygen as well as less blood. So for our brain, we can have focal cerebral ischemia, which is in a focal part of a brain, so a specific area of the brain, and that occurs with a stroke. Or we can have a global cerebral ischemia. So global meaning the entire brain is impacted, and that will occur with a myocardial infarction or a heart attack, where your heart's not able to produce enough pressure to send blood to the brain. Now, ischemia, like I said, doesn't just mean you have less oxygen. You also don't have a lot of blood going either. So there are some additional issues with ischemia. So it also interferes with the delivery of our energy stores. So you're also not going to be able to deliver glucose like normal. In addition, you're going to damage your blood vessels because our blood vessels aren't going to have the blood in them that they should. So it can lead to vasomotor paralysis and vasoconstriction. And you're going to get changes in the blood itself like clotting. which obviously can lead to more blockages. So let's take a look at an example of hypoxia and ischemia. So a little boy fell through the ice into a lake, and he was rescued after 15 minutes, and he recovered completely. His grandfather suffered a stroke in the hospital, and although blood flow was restored within 10 minutes, he suffered permanent disability. So why did they have such different results? So remember, the little boy fell through ice and he was down there for 15 minutes, but he recovered completely. The grandfather, who was older, had a stroke and it was restored within 10 minutes, but he had permanent disability. So the reason is because the little boy still had blood flowing. So he had global hypoxia. So because he's fallen through ice, blood is still flowing. It's just he's not able to breathe, so he doesn't have enough oxygen. In addition, because he fell through ice, that's going to play a role as well, he's going to have hypothermia. And with hypothermia, your demand for, your metabolic demand actually decreases. So not only does he need less energy, but he's also, he needs less energy, which is good because he has less oxygen, but he's still delivering glucose to the brain, and so he could do anaerobic metabolism to make ATP. In addition, and another important thing is that, so there we go, the brain is still able to do anaerobic metabolism, but another important thing is that waste is continuing to be taken away. So because blood is flowing, the waste products that are created by the cells can be taken away from the cells, the tissues, by our circulatory system. So all of this means that the little boy is going to recover better. Plus, he's young, and we know age plays a role as well. The grandfather, on the other hand, has a complete interruption in blood flow to a part of the brain. And so he doesn't have blood, he doesn't have oxygen, he's not getting waste taken away, and he's older. So he's not going to have as good of an outcome. So let's take a look at how blood gets to our brain. So cerebral blood flow. So this is a lateral view of our brain. So the front of the face is over here. Here's the back, and this is basically the side. We have two internal carotid arteries. So there's one on this side. Imagine one is on the other side of this screen. And they're going to go up to the brain, and they're going to branch each of them into an anterior cerebral artery and a middle cerebral artery. So our two anterior cerebral arteries from each of the internal carotids will feed the anterior portions of our brain. So the frontal lobes, for example, the medial and superior surfaces of the brain. The middle cerebral artery will feed, again, there's two of them, one on each side, will bring blood to the lateral surface of the brain. So the speech centers, the sensory cortex, the motor cortex. Now, we still haven't brought blood to the back, so that's done through our basilar artery. So we only have one of those, and that one will come up and it will branch into our two posterior cerebral arteries, which will supply blood to our occipital lobe, and we also get blood supplies to our brain stem through here. So the medulla, the pons, the midbrain, as well as the cerebellum, the temporal lobes, the thalamus, all get blood through these arteries. Now, another important structure for blood flow to the brain is visible when we look at the brain through a ventral view. So now we're looking up the brain. And again, just to orient yourselves, these two red short guys are your internal carotids. Imagine they're coming from outside the screen. They each split into our anterior and our middle. Here's our anterior and our middle. Here's our one basilar splitting into our two posterior cerebral arteries. Now, if you look at the magenta lines, we have these magenta lines, and what they do is they create an important structure known as the circle of Willis. And what the circle of Willis does is it allows blood to flow so that if we have a blockage in any of our major arteries like our internal carotid or our basilar artery, then we can still supply blood to the brain by using the circle of Willis and finding an alternate route. So the circle of Willis is made up of our anterior communicating artery, which connects our anterior cerebral arteries together, and then our posterior communicating arteries, which connects the middle to the posterior cerebral arteries on each side. So let's say we had a blockage in this internal carotid artery. Well, if the circle of Willis was not there, that means this anterior and this middle cerebral artery, all of this would not get any blood. So our brain, there would be a significant portion without blood flow. But because we have the circle of Willis, even if this internal carotid is blocked, we have blood coming up the basilar and the other internal carotid, and they can go around the circle of Willis and still feed the middle and anterior cerebral arteries that are impacted. So it's not going to restore complete blood flow, but it is going to help maintain some of the blood flow. So a really important structure. So here's just another view. This is more anatomically correct. So we see the internal carotids, our anterior cerebral arteries, our anterior cerebral arteries and our middle cerebral arteries. And then we have our anterior communicating here, and then our basilar artery coming up to our two posteriors, and here is our posterior communicating artery here. And you can see it within the brain as well. So a doctor heard something odd in a patient's carotid, so in their internal carotids. He found that in one there was a 90% blockage, and in the other there was a 20% blockage. The man's aunt had a stroke in which blood flow in her left anterior cerebral artery was blocked, causing serious damage. So how can her nephew still be walking around even though he had a bigger blockage? And the answer is the circle of Willis saved his life. So in the man, because the blockage happened in the internal carotid arteries, blood from the less blocked carotid as well as the basilar can go around the circle of Willis and feed the areas of the brain that's impacted. The aunt is less fortunate because her blockage is in the cerebral arteries. Hers was in the anterior cerebral artery, and so there's no alternate route. So her blockage is after the circle of Willis, so then the circle of Willis can't help. So that's why she had more permanent damage. So what controls cerebral blood flow? Well, it's controlled by autoregulation, as is blood flow to other areas of the body. So autoregulation is capable or is able to occur because we have smooth muscles, and we know our smooth muscles can regulate themselves either through stretch, or we have as well as other kind of factors like paracrines and autocrines. The sympathetic nervous system plays a role. We know that sympathetic activity to our blood vessels causes vasoconstriction. If we remove that activity, we get vasodilation. And then we have metabolic factors that can also influence cerebral blood flow. So carbon dioxide, hydrogen ions, oxygen concentration. Depending on the need, we will either increase or decrease blood flow to the brain. So, for example, if carbon dioxide levels were elevated in our brain, we would vasodilate to bring more blood to that area, and as well as more oxygen. So now let's move on to strokes. So strokes are brain attacks, and we have two major types of strokes. We have ischemic and hemorrhagic. So in an ischemic stroke, the stroke is due to ischemia. So we have a blockage. So it's caused by an interruption in blood flow in the cerebral vessels. And these are the most common type of stroke. They account for about 70 to 80% of all strokes. The other type are hemorrhagic, so the name tells you it's going to be caused by a hemorrhage. So you're going to have bleeding into the brain tissue, and that's usually going to occur because the blood vessel ruptured as a result of either high blood pressure, hypertension, an aneurysm. We talked about how it's a dilation of our blood vessel, but our blood vessel's weaker, so it can hemorrhage. We have arterial venous malformations, as well as head injuries, all contributing to hemorrhage. There's also a transient ischemic attack. So the word transient tells you these are transient, so they come and go. So the blockage only lasts for a few minutes. So we have an interruption in blood to part of the brain, again, but it is briefly interrupted. So the symptoms are going to be similar to a stroke, but they just last, let's say, a few hours. So you'll get numbness and weakness in the face, arms, or legs, especially on one side of the brain, one side of the body, depending on which side of the brain was impacted. Remember, the left side of the brain controls the right side of the body, vice versa. It can lead to confusion, difficulty talking or understanding speech, because obviously those are important functions of the brain. You can have trouble seeing, as well as difficulty with walking, dizziness, balance, and coordination. Now, what increases your risk for a stroke? So there are several risk factors, as you can see. One is age. So as you increase in age, your risk increases. Men have a higher risk than women. African Americans have a higher risk than Caucasians. If you have a family history, your risk is higher, as well as having hypertension. Now, smoking is also a risk factor, as well as diabetes mellitus. If you have asymptomatic carotid stenosis, so this is a narrowing of your carotids. And then we have sickle cell So that makes sense because sickled red blood cells, we talked about how they can cause blockages. Hyperlipidemia. Well, that makes sense as well because we talked about how increase in lipids increases the risk of atherosclerosis, and that can cause a blockage. And then we have atrial fibrillation. This is basically an abnormal heart rhythm. And what it does is it impairs blood flow in the atria, and so blood can kind of swirl around in the atria, causing clots to form. And then eventually that clot will go into our circulation and can cause a blockage, leading to a stroke. So the deficits that are related to a stroke are really going to depend on what area of the brain is impacted. So if it's part of the brain that's involved in movement, so whether it's the primary motor cortex or the basal ganglia, then you might have motor deficits. It can be related to speech issues. So dysarthria would be motor speech disorder, characterized by poor articulation. Or you can have aphasia. This is loss of ability to produce or comprehend language. So we have expressive aphasia, where you have difficulty producing language, and then receptive aphasia, which is difficulty comprehending language. And then there can also be cognitive deficits as well as others because, again, our brain does so much. Now we're going to move on to seizures. So seizures are abnormal nerve firings from neurons in the cerebral cortex. And basically these nerves are firing uncontrollably, without control. So these are discrete clinical events. They're associated with signs and symptoms, which will vary depending, again, on which area of the brain is seizing, so which neurons are seizing. And manifestations will generally include a sensory phenomenon, motor, autonomic, or even psychic. Again, depending on if it's the sensory cortex or the motor or the areas of the brain related to autonomic function. If it's a motor output, so if you have a motor seizure where your entire body is kind of convulsing, then obviously that's called a convulsion. There's also epilepsy. So epilepsy is a recurrent, unprovoked seizure. So the key word here is it's recurrent. It's also unprovoked. So some common causes of epilepsy include a tumor. So basically, again, it's going to be anything that really kind of alters our brain. So a tumor, chemical imbalance like low blood sugar or sodium, a head injury, chemical injury, so toxic chemicals or drug abuse, alcohol withdrawal, or any kind of brain injury like a traumatic brain injury. All of these basically alters our brain, and so it can lead to these recurrent seizures. Now we can categorize seizures. The two major categories are partial seizures and generalized seizures. And if we don't have enough information, then it will be unclassified until we can get more data and classify the seizure. So in a partial seizure, the electrical disturbance is limited to one hemisphere. So you will seize in one cerebral hemisphere, either the right or the left. And partial seizures are subdivided into simple partial and complex partial seizures. So in a simple partial seizure, one hemisphere is seizing, but you retain consciousness. In complex partial seizures, one hemisphere is seizing, but you lose consciousness, or you have impaired consciousness. In generalized seizures, it's more general. So both hemispheres are going to be impacted. So it makes sense that you would lose consciousness in generalized seizures. And generalized seizures are further subdivided into absence, atonic, myoclonic, and tonic-clonic. And I'll talk about them here. So an absence seizure is also known as a petite mal. So petite means small, mal is bad. So it's a small, bad, generalized seizure, so an absence seizure. So here you'll have that loss of consciousness, so lapse of awareness, sometimes with staring, begins and ends abruptly. It typically lasts only a few seconds. So it's the smallest bad one of a generalized seizure. Then we have atonic seizure. This is also known as a drop attack. So here's the word tone inside atonic. So in this case, the A means an absence of tone. So what happens is you lose muscle tone. So your muscles all essentially kind of relax and become flaccid. And so you get a head drop, loss of posture, and you collapse, hence known as a drop attack. And again, all of these you lose consciousness. A myoclonic seizure, in this case, you actually have contractions. So you're going to have brief contractions of your muscles like sudden jerking, and it occasionally involves one arm or one foot. And then, or one leg. Okay. And then you have the biggest one, that's our tonic-clonic seizure, also known as a grand mal seizure. So grand is a big bad one, or a convulsion. So here you're really going to go between the tonic and the clonic phases. So in the tonic phase, remember tonic, it has the word tone in it. There's no A in front of it, so it's not an absence of tone. It's a presence of tone. So here your muscles will contract and be stiff. So it begins with stiff limbs with muscles contracted. And then you will go into the clonic phase where you'll get the contraction. So then you'll go into the jerking motion. Now, during the tonic phase, one thing that's obviously an issue is that your respiratory muscles might contract and stay contracted, and that means you'll stop breathing, and so you can start to see cyanosis of your lips, your nail beds, and your face because you're not breathing. And then typically the breathing will come back once you go to the clonic phase, because here you're actually having contractions, so the jerking contractions. So think of the tonic phase as you have sustained tetanus, and then in the clonic phase you have the muscles actually relaxing and contracting. So we will end with this question. Which type of stroke is the result of a ruptured blood vessel? And the best answer would be a hemorrhagic stroke. Okay, thank you.